So the way this will work is I'm the moderator. I'm Steward Decker. We have several panelists, three who I will introduce and ask a few questions, an introductory question to. And then if you guys could use the chat to put in any questions you kind of want these experts to answer, I will ask them once they're done with their introductory questions. So I'll get going. So like I said, I'm Steward Decker. The reason I'm here is because I started bugging Joy a bunch. A few years ago, I wanted to try to update the OMA's policy on climate change. And that's because I wanted to convince organizations within medicine who had some advocacy clout that weighing in on legislation specifically targeted towards climate change was worth doing. And just like our last speaker, I believe strongly that there's health in all policy, and that some of the policy that is most impactful to overall health is policy that affects climate change. And like our last speaker said, that could be something that's really obvious, like carbon legislation, or maybe less obvious, like transport or transportation or housing legislation. And having physicians and physician organizations or medical organizations comment on those things and kind of bring out or flesh out the health in that policy can be really impactful. So as it turned out, there was quite a few other people who were thinking the same thing and whose first instinct, just like mine, was to bug Joy. So thankfully up for us, Joy is patient and an excellent leader for the OMA. So squeaky wheels ended up on the OMA's climate and health work group. And we've had several meetings over the last year. So far, we've put together a bevy of recommendations, a couple of which are to update the OMA's climate change policy, and further that the OMA co-sponsors some CME concerning climate change, which is partially why we are here today, that we make a plan to reach carbon neutrality as an organization by 2030. So we'll see what that plan looks like in the coming years. And then also to help members learn how to make changes in their practice and organizations, not just their home life, but also their professional life, to help green the healthcare system. So that's the kind of term that is often used. So this last point is why we're here today. These panelists are here because most people are well aware of the dangers of climate change, both in terms of societal harms, but also in terms of individual health. And we don't really need to teach you all about that again. We all know that there's huge changes coming in vector-borne illnesses, heat disease, lung diseases, natural disasters, unnatural disasters. But it's always been harder to know what to actually do about climate change. It's easy to know that there are worrisome things happening and that we get to be kind of scared or prepared, but it's hard to know what to do to help prevent it. So that's why our panelists are here. At this introductory part, I just wanted to point out one cool resource that I have found in our work so far. So this is a resource, a toolkit, if you will, put together by the American College of Physicians. And I think that we're putting it in the chat. If not, I can, oh yeah, it is in the chat. I can see that right there. So if you search for ACP climate change, the first result should be this climate change toolkit as well. And the whole idea is to reduce greenhouse gas emissions in your practice. It's a series of PDFs starting with why greening the healthcare sector is worth doing. And then it has these beautiful just PDFs broken out by region. So there's Northwest, there's Southeast, there's Alaska, there's Hawaii for specific talking points for wherever you may be. There's patient handouts, which I have printed and have in my waiting room, that talk about why climate change can be helpful for them and what they can do about it. There's a PowerPoint presentation that you can download and use, including those regional talking points, in case you need to convince some board to let you do some of this cool stuff. So having gone through that recently, I have a couple just really quick, easy tips to throw out to you to whet your palate a little bit. So first, starting a commute reduction incentive. So there are organizations like Drive Less Connect operating here in Oregon, and they do all of the actual work and logistics for you. So you basically just hire them or ask them to work with you, and they run the prize program and the tracking program, and they have all of the infrastructure, both hardware and software, for getting gift cards to people for changing their commute so that it's not a single solo car trip. Second, you could upgrade your healthcare system's fleet of cars to be electric or hybrid. And then lastly, you could change all of the lights, including exit signs, to be LEDs instead of fluorescent lighting. So a couple facts about that, which just kind of stick in the brain easy. If every household in America did this, if every household changed from fluorescent lighting to LED lighting, we would have $5 billion in yearly savings. And that's just the financial incentive, not the energy incentive. So for a hospital with 300 exit signs, so the computer program said that that's about 150 bed hospital. And I didn't go around and count my exit signs, so I don't know. But replacing traditional signs with LED signs resulted in an annual savings of $14,000. And then they calculate the payback time to be 1.15 years. So those kind of things should be like music in the ears of your CFO, but also happily contribute to greening that healthcare sector. So in that document with the ACP, and what you'll hear from these lovely people next, or who come in this panel, are some other ideas for how you can kind of help your practice and your organization succeed in this. So let's transition to the panel. So the first question is for Colin. Colin Cave is the Director of External Affairs, Government Relations, and Community Health at Northwest Permanente. He oversees Northwest Permanente's corporate social responsibility program and leads their B Corp efforts as the first physician-owned medical group in the world to become a certified B Corp. He authored the Northwest Permanente's Climate Action Plan and has led the development of their environmental guidelines. So, Colin, and I hope your microphone works too. I should have let everybody test it beforehand, but I understand that Northwest Permanente is a certified B Corp, raising the importance of people in place to that of profits. So what has Northwest Permanente done over the last 3 years to advance environmental leadership?
Thanks for the question, Stewart. Thanks for the introduction. And I will assume that you're able to hear me, correct?
I'll give you a thumbs up.
All right. So B Corps are businesses that meet the highest standards of verified social and environmental performance, public transparency, and legal accountability to balance profit and purpose, led by B Lab out of Philadelphia. And certified B Corps are for-profit companies that then use the power of business to build a more inclusive and sustainable economy. They meet the highest verified standards of social and environmental performance, transparency, accountability, and all are certified by the nonprofit B Lab. They thrive in inclusiveness and interconnectedness, and they support each other. So as we looked into what B Corps were as Northwest Permanente, we were pleasantly just surprised to find out that basically we were a B Corps, we just weren't certified as one. Now, Kaiser Hospitals and Health Plan is a not-for-profit out of Oakland. They own and operate the hospitals and clinic at the Kaiser regions around the country. Kaiser in every region is associated with an independent for-profit medical group called a Permanente Medical Group, and I belong to Northwest Permanente, thus the Permanente part of Kaiser Permanente. It is the Permanente medical groups that can become B Corps because we are for-profits. And we decided that in 2016, we were going to do that. We took the launch. And in 2016, we changed our articles of incorporation as required under Oregon law. And we passed a very intense assessment that 85% of most companies do not pass first time to become the first physician-owned medical group in the world to become a B Corp. Very proud of that. And people and planet elevated to the level of profits. So it takes a couple of years to get your foundation then built. And that's what we did from about 2016, 2017, 2018. And in 2019 is when we really planted our flag that environmental leadership would be where we put our energy and our focus, because the environment is so fully aligned with, integrated, affecting the health of both us and the communities that we serve. And our mission statement is that we improve the health of our members and the communities we serve. So this was just something that was inherently obvious to us. And in 2019, to start this off, we developed the Climate Action Plan for Northwest Permanente. This is our flag, and it has 8 main principles that guide us. Just hitting them on the high level. First of all, we want to ensure that the most vulnerable populations in our communities have a leading voice in planning for climate interventions. We want to minimize our greenhouse gas footprint and offset the carbon our core business creates. We want to work with our business partners and vendors to insist on climate smart facilities and operations. We want to ensure the health of our supply chains by supporting local and regional purchasing and creating redundancies in our procurement practices. We want to adopt our medical model to anticipate disease burdens our communities will face in the coming years, secondary to these climate impacts. We want to work with our business partners to create backup plans for insurance failures, given everything that's going on. We want to make the case for climate smart business as a strategy for financial solvency amidst growing uncertainty. And we want to take a leading stance as a medical group on the need for climate action. Essentially, what this climate action plan says to the world is we're going to minimize our impact on climate change. We are going to understand that we as physicians and clinicians and a system need to anticipate what's going to happen in the future, that we need to be present for to meet our member needs, and that we are going to make sure that those groups in the community that are the most affected actually have a voice at the table. We plan on being able to provide our medical care now and in the future as we go forward. In 2020 then, in the middle of COVID, we still were able to enact, after about 10 months and bringing together all of our subject matter experts, again, the first that I've been able to find significant environmental guidelines to help a major medical group in the country. And these guidelines are pretty inclusive. They include emergency preparedness, environmental leadership, understanding and enhancing the mental health and community resilience needs, greenhouse gas calculation and a reduction plan, facilities design, operations to include cost avoidance, waste reduction, employee satisfaction, department ownership. Every department can do something. And Brian Chesebro is going to be talking, but even within Northwest Permanente, we were able to, within a year, reduce our use of desflurane, moved to sevoflurane, and save tons of CO2 equivalents into the environment. And so the environmental guidelines had many other aspects, but it took about 10 months. All of our subject matter experts, we're very proud of that. Happy to share that if anybody wants to send me an email, is interested in that. And then in 2021, this year, again, in the middle of COVID, we've had since 2015, we've been collecting and collating data on all of our virtual visits, which have expanded in scope and type. And we were able to go back utilizing our data from 2015, 16, 17, 18, 19, and then 20, and then looking at the shift in inpatient or in-person outpatient visits to the virtual shift that occurred with COVID. And we were able to look at not just the healthcare outcomes, but we were able to look at the environmental load, the environmental outcomes as a result of this. And in a paper that we published with a couple of researchers out of Harvard Brigham and Women's in the Journal of Climate Change and Health, basically our virtual visit paper. And it shows that between 2019 and 2020, as we instituted far more virtual visits, we were able to save the production or eliminate the creation of about 10,000 tons of CO2 equivalent simply by reducing car transport to and from meetings, office visits with physicians. And this created a new term that we hope is going to be useful to everybody who's doing environmental research. That's called the ambulatory visit carbon intensity. And as we were growing our members from 2015 to 2019, we saw increase in membership, but of those new members, there was a greater proportion of virtual visits. And so we were actually able to see a slow decrease in our ambulatory visit carbon intensity over those years. And then we saw a huge drop with COVID and with really rolling out the virtual visits. Now, we've come back to a more 60-40, 40-60, 50-50. We're not sure where that's going to end up, but virtual visits can be looked at in many different ways. And what we really want to emphasize is that they really reduce the creation of CO2 into our environments and the communities that we serve. And then the last thing I'll say, and then we can move on to my other esteemed panelists, is that we have just finished purchasing 76% of our emissions from 2020 as offsets, and we have joined the B Corp Climate Collective. But we're not just going to be carbon neutral by 2030, we're going to be carbon neutral by 2025. And we're 3/4 of the way there. So that's what we have been able to do in the past 3 years after becoming a B Corp 5 years ago. We're very proud of our work, and we also want to share our work so that everybody can steal it, use it, import it, and we're happy to answer questions. So thank you, Stewart. I'll turn it back to you.
Great. And it is so delightful. I think that the purest part of these panels is identifying things that we can steal from other people. So I'm glad that you highlighted that. My next question and introduction is for Marianne Parshley. She currently practices internal medicine at Providence Medical Group. Frontline clinical teams see firsthand the health impacts of climate change and heat emergencies, fallout from injuries from wildfires, flooding and damage from hurricanes. These are things that she has really been interested in. So oftentimes clinicians feel that they or we don't really know where to start in working upstream and helping combat climate change as well as mitigate the increasing consequences downstream. So basically, kind of a big open question. I know you've worked on this a lot over the years. Where would you suggest that clinicians start if they're interested in doing the same?
Thanks, Stewart. And thanks, as a regent of the American College of Physicians, I want to thank you for picking up on our climate change toolkit, because I think it's great. And there was a policy paper put out in 2016. It's worth looking at with recommendations. I also wanted to point out, thinking about our keynote speaker, the most impact of climate change is going to be on the high-risk populations. Those are communities of color, low-income communities. Think about New Orleans and people on the floodplains and behind the dikes. Older adults in Portland with the heat dome, 600 people died. Many of those were older adults who did not have air conditioning. And our kids. And even more importantly, this is an intergenerational justice issue. So we're working for the next generation to come behind us. In August, I don't know if you all saw, but the Intergovernmental Panel on Climate Change issued its 6th scientific assessment report. This is the smallest gap between the assessment reports. The previous one was in 2018. They gave a clear evidence-based acknowledgement of the reality and speed with which rising CO2 has and will impact our environment, but they also left this clear hope with a narrow pathway, a small window of time during which we can mitigate rising temperatures by reducing our carbon emissions. And the only way we're going to get there is working together, both on the personal level and on the institutional and work level. There are 3 ways we can address climate change. One is the adaptation of natural and human systems, some of which Dr. Chesebro and Dr. Cave talked about, but also it's going to be ongoing as the temperatures rise. The second 2 are climate change impact mitigation and prevention, reducing our emissions. So where do we start? That's really the heart of the matter for me as a primary care doctor, because sometimes the problem looks so big, I'm not sure where to start. So I start at home, and I start in my community. The first thing we need to advocate for is the increased human power transportation, using our feet, using our bikes. And Stewart talked about that a little bit. We also need to increase mass transit. And for those 2, I also want to comment, because of our keynote speaker, that those impact people who are living in the zip codes that have less resources. So human powered transportation, walking and biking in some places may not be safe. In the neighborhood where my clinic is, it's becoming less safe. But we still do it, and we still need to advocate for it. The thing about mass transit is those people with less resources often are on mass transit, bus and MAX. And in the heart of the outbreak of COVID, many of the people who still had to go to work in service industries were riding mass transit, which increased their risk for COVID, but we still need to do it. We can buy electric and hybrid vehicles. We don't have to have the wonderful Tesla. I bought a used Leaf, and from March 2020 to July 2020, our household didn't buy a single tank of gas. We need to think about our travel. both professional travel and individual travel. Is it necessary? Is it desirable? Are there alternatives to it, like virtual meetings? And if you really want to go or you really have to go, is it mitigatable? There are options of certified carbon offsets we can do. We can also support land trusts that are doing forest preservation. We can look also at our energy use in the Pacific Northwest. We really have the benefit of having hydropower, wind power, and solar power. We can work with our power companies. For $6 extra a month at PGE, you can choose all sustainable and renewable power. And docs and clinicians should be able to afford that, even if some of our community members can't. And we can reduce our gas and oil by going for solar hot water. We can choose electric heat pumps over gas furnaces. We can go to electric stovetops, and we can invest in home or clinic solar or community solar. There are a couple programs in Oregon, one's down in Medford that's community solar. It's partnering with community centers and churches and other buildings to put solar in. People invest in that, and then they get back their share of that investment as time goes by. And so if you have trees that cover your house, or you can't afford your own private, you can purchase a share in a community solar. At work, again, incentivizing human-powered and mass transit. Providence provides a TriMet pass to all employees who wish it as part of our benefits. We can encourage virtual meetings and telehealth, as Dr. Cave talked about. Even a 10% reduction in travel for professional meetings can make a huge difference. We can use LEDs and timers on the light and motion sensitive light switches in our clinics. So if you have a room that doesn't need to be lit most of the time, the motion sensitive light switches will turn off the light even if we forget. Computers can be switched to sleep or hibernate if they need to be left on. And we can turn down the thermostat. And back in 2008, we were looking for ways in the economic crisis to cut the cost of doing business. We turned down the thermostat from what was functionally 75 degrees in every exam room to 72 degrees. And that can make a huge difference both at home and in our clinics. And again, clinics can use renewable energy options. I think all clinics, independent practices, and larger institutions should shoot for at least 50% reduction of carbon emissions by 2030. And we need to put pressure on our leaders to do that. And we can also advocate for our larger allied healthcare institutions to adopt environmental sound policies. For our professional organizations, and I'm going to put my professional organization hats on, number one, we can make carbon neutrality a strategic goal for all future planning. That means all activities of our professional organizations, the operations of our organizations. We need to develop plans to reduce or eliminate carbon emissions by 2030. Even if we don't achieve it, we'll get a lot farther than if we don't have a plan and we use sustainable and renewable energy choices. We need a plan for low impact regional or national meetings. So if the meeting can go hybrid, great, make it hybrid. If it can go virtual, maybe so. None of us like sitting on Zoom all day long. But we can also offer links to carbon offsets if people have to travel long distances so they can mitigate their plane flights. We can advocate for shifting investments by our professional organizations to ESG funds, environmental, social, and governmental value funds. They also tend to be better run because they have to be. We can contribute to our professional organization PACs like OMPAC, hint, hint, because they do the advocacy for us at the state legislature and federal levels. And we can encourage all of our professional organizations to join the Medical Society Consortium for Climate and Health membership. It's now 36 member societies that have come together across the US, including ACP, AAFP, AMA, ACOG, and on down the line. If your professional organization doesn't belong, they should. And we can advocate. we can advocate through AMA, ACP, and all of our professional organizations. We can meet with our Congress people. We can send them letters. We need to be aware of environmental legislation that's really important. And we can work with LMA to advocate in the state legislature. I'm going to be really quick, and I know I'm running out of time, but in 2019, there was a cap and invest bill that had all the votes to pass until a certain party walked out and they failed to give us a quorum. And in 2021, they came up with a clean energy bill that is requiring the energy, the electric companies in the state of Oregon to become carbon neutral. And they were behind it, actually. So where do we start? Just pick one or two things that appeal to you and are easy to do, and do those first, and then make a plan. And balance your work and lifestyle changes with your need to have fun and enjoy the planet.
Thank you so much, Marianne. And some of you who were here last year may have remembered my talk with my local public health director, Jennifer Little, and just one of the things Marianne said reminded me of that, where advocating is a really delightful thing to do, and it can be a big impact, but so often we don't know when a bill is coming up, or when they're going to be talking about it, or what to say, or how to get into a position to say it. And the easiest shortcut to that is make a connection with your public health director, who can then kind of tell you when things are happening and where you should be. Our next panelist is Dr. Erika Moseson. She's a pulmonologist and intensivist with the Legacy Medical Group. She's one of the American Lung Association's Health Professionals for Clean Air and Climate Action, and also serves on the Environmental Health Policy Committee of the American Thoracic Society. She runs airhealthourhealth.org and also hosts the Air Health Our Health podcast, which promotes healthy air in general, and in particular to educate and advocate around the link between air pollution, climate change, equity, and health. So, Erika, you have a podcast. Can you tell me how it's gone, what lessons you've learned, and how physicians might be able to make a difference in health equity related to the environment, pollution, et cetera, along the way?
Absolutely. Well, it's been a journey. So first of all, I don't know about other people, but I didn't learn any of this in med school or residency, or honestly fellowship, because I think we did focus, as Dr. Eitan was talking about, more on those individual frames, right? This kind of individualistic nature of medicine, rather than kind of realizing how much, the air we breathe determines our health, and then how much of what determines the air we breathe is determined by our zip code. And so, I remember coming down from the mountaintop, doing fellowship at OHSU, and then, working in the ICU and pulmonary clinic at Emmanuel Hospital, right next to I-5 freeway in a historically redlined district, and just seeing the difference in asthma and a whole variety of health outcomes, but, particularly asthma, really striking, very striking. And I started learning a lot more about these things, and was approached by the American Lung Association as a member of Oregon Thoracic Society to kind of meet with legislators and talk to them about some important diesel bills and tobacco and other things. And as the more I talked to state representatives and senators, just realizing how little they heard from doctors was striking. And it's all these systemic reasons, because it's, they'll say, oh, there's a hearing on this bill next Tuesday. Can you testify? No, I have a clinic, or I'm in the ICU, or I'm working and I can't drive to Salem. And and realizing how outsized the impact from industry is, and all very well-meaning people, but saying, well, you can't regulate my truck, like I've got to do my construction and do my job, and all these things. And so I think physicians really have a very powerful opportunity to have a health lens. So I think people kind of vastly underestimate the burden of a disease like asthma, right? Well, we see it every day. We see how much it costs parents having to take their kids to the doctor over and over again, kids missing school, if you're, a pediatrician, or if you're an adult, medicine doctor, you see how much it costs your patients to kind of show up to, get inhalers, miss work, all these things. And so I also think that physicians don't realize that we are often the only person in our patients' lives who actually has a really deep understanding of science. And I think we're all kind of, jack of all trades, master of none. So we don't think of ourselves as scientists a lot of the times when we're physicians, but we really are, or we are at least all experts in translating the messy science of healthcare and studies and that sort of thing into how patients should change behavior and lives, and what medicines they should put in their body. And I think now with these, catastrophic wildfires, these heat waves, people are really kind of opening up and understanding this in a very granular level in their lives. And also with the COVID-19 pandemic, we've all seen the importance of kind of being able to be a trusted voice for science in your patients' lives, although sometimes we all still fail to have people get vaccinated. But I also try to empower my patients with this information. I'll tell my patients with asthma, there's as many types of asthma as there are people with asthma, right? The triggers that set you off, the things that have led to you having asthma right now are kind of individual. It's a mix of your genes, the air you breathe, where you've lived, all these things. And that's an ongoing issue. Actually, one of my favorite podcast episodes I did was with a patient who was an inspiration for me a little bit in this work. Her name's Asia Allen. This is all HIPAA approved and, releases have been signed, who grew up in North Portland. And she had her whole childhood in North Portland, went to all her schools. If you just look at the map, or just like right by freeways, right by construction sites and all this stuff. And there's robust data showing, growing up by freeways, growing up by construction sites, just this really disproportionate impact of air pollution on people's health. And a lot of people know that North Portland's one of the historically redlined districts, right? So these housing policies that were, made decades ago that led to these massive inequities in where people live, and these sacrifice zones from an equity standpoint, just these places where we've decided this is where the land is cheap, this is where we're going to build the freeway, this is where people are going to live and breathe this air, has just, really impacted her health. And so I think it kind of helps connect what Dr. Eitan was just talking about in his last talk about what we can do. So I would just say that you're all experts, you are all experts in the diseases your patients have, and it's not a too long of a step to kind of learn a little bit more about climate change, pollution, and how it affects whatever disease you treat, because I guarantee it does. And if you want to learn more, if you're someone who listens to podcasts on your commute, you can kind of scroll through the topics on the Our Health podcast. There's stuff on cardiovascular changes, pollution, telling lawmakers how much an inhaler costs and that your patient might be on 3 of them will open their eyes real quick to healthcare costs and how they should care about this from a budget standpoint when they're thinking about the Medicaid budget. And telling people that we now, since the 1990s, have a month more pollen season, and the pollen is now more intense and more allergenic because of the climate change that's happened in the Pacific Northwest alone, also opens people's eyes to how lives are just a little more miserable because of climate change, and how addressing it can really save a bunch of money, which is what people really care about, but also health and lives. So just recognize that you as a doctor, as a physician, are an expert, and you're probably the biggest expert people know in their own personal life, and that connection is really important. So speak up.
Great. Thank you so much, Erika. You guys may have seen the little tab at the top saying we have limited time left in the breakout session. So the nice thing is we haven't had a lot of questions so far, but we'll just let Dr. Chesebro take it from here. So Brian practices anesthesiology with the Oregon Anesthesiology Group at Providence Portland Medical Center in Portland. Also the Oregon Regional Medical Director of Environmental Stewardship for Providence. So Brian, you are the Oregon Regional Medical Director of Environmental Stewardship for Providence, which I understand is a brand new position. Can you tell us a little bit about its inception and what the role has been like for you?
Sure. Thanks, Stewart. It's really an honor and a privilege to be here with all of you on the panel. It's so inspiring to hear each of your stories. You're absolutely right. The role that I'm in now is new. It started in late 2019, so it's kind of going on about 2 years. But my direct involvement in environmental stewardship within healthcare really began in around 2016. And at that time, personally, I was experiencing some pretty severe solastalgia or eco-grief at kind of the direction of environmental stewardship and where we were heading as a global society. And in order to kind of redirect myself toward a more active hope kind of perspective, I deliberately did what Marianne recommended and took a pause to kind of examine my own stewardship throughout my life. And I quickly realized that my greatest area of opportunity as an anesthesiologist actually lay within healthcare. Prior to this current stewardship role, much of my non-clinical work was really focused around clinical quality improvement and healthcare informatics. And so I decided to kind of merge those two together, and pulling in the quality perspective, we designed a quality improvement project that focused on outcome measures of environmental stewardship, namely the direct Scope 1 greenhouse gas emissions associated with inhaled anesthetics. Starting the project at Providence, Portland, it quickly spread throughout Oregon Anesthesiology Group, across Legacy, Salem, and the other Providence acute care hospitals in Oregon. To date, that project has reduced these emissions in Oregon by 95%, and we're in the process of expanding it to cover all 52 Providence hospitals in the system. Eventually, that work kind of got the attention of Providence, Oregon executive leaders, and they asked me to present the work and tell the story to several large groups of directors and managers. The issue clearly resonated with that audience, and the executive leaders, shortly after that presentation, they approached me and to discuss how best to expand this work beyond just the anesthesiology. So really, while Providence has been active in stewardship for several years, the value of this specific medical director role and the involvement of a physician to lead the work was really made clear following this kind of data-driven grassroots quality improvement project that focused specifically on healthcare carbon emissions. And I know we have less than a minute, right? And I would encourage those of you who are involved in clinical quality within your practice or your institution to use that as a entry point and to draw the attention of your colleagues and health system leaders